oxygen. Now let's talk about a very important molecule that is found inside of red cells that can affect oxygen uptake by hemoglobin. And that molecule is 2,3-bisphosphoglycerate, or 2,3-BPG. This is its structure shown on the screen here. And 2,3-BPG is always found in red cells at some level, and it promotes oxygen release from hemoglobin. It's a negative allosteric effector. This means that when 2,3-BPG binds to hemoglobin, it causes less oxygen to bind. So high levels of 2,3-BPG are associated with decreased oxygen affinity for hemoglobin, and therefore oxygen becomes released and there's more delivery to tissues. 2,3-BPG is created from 1,3-BPG, which is an intermediate in glycolysis. Remember, red cells do not have mitochondria, so they depend on glycolysis for metabolism. And 1,3-BPG is a glycolysis intermediate, and red cells have an enzyme called BPG mutase, which can convert 1,3-BPG into 2,3-BPG. So in other words, red cells are sacrificing a little bit of ATP, in other words, a little bit of glycolysis, in order to make 2,3-BPG, but that's important because it modifies oxygen uptake. So as I said before, there's always some 2,3-BPG in red cells, but the amount can go up when red cells are exposed to chronic hypoxia. And this should make sense to you based on what we just talked about. 2,3-BPG causes hemoglobin to let go of oxygen. So in the setting of chronic hypoxia, you want oxygen to be released, and therefore that's when 2,3-BPG levels go up. So patients with COPD can have high levels of 2,3-BPG. So can patients who live at high altitude. So can patients with chronic anemia. In all these situations, there's a chronic level of hypoxia in tissues, and that leads to red cells making more 2,3-BPG. So to explain the impact on oxygen binding of 2,3-BPG, let's consider the situation of high altitude. So if you're at sea level breathing room air, the PaO2 you're going to find in the alveoli of your lungs is usually about 100. And then as we said earlier, out in the tissues, the PaO2 is about 40, and that causes the oxygen saturation of hemoglobin to go down to 75%. If you're up at high altitude at Machu Picchu in Peru, the PaO2 you're going to find in your alveoli is much lower. It's about 75. This means that we've moved down the oxygen hemoglobin dissociation curve, so we may not fully saturate hemoglobin. And then when we get to tissues, we're only unloading down to 75%. So that's some oxygen, but not as much as we could potentially release if we modified hemoglobin. And so that's what 2,3-BPG is going to do. It's going to shift the curve to the right, just like we talked about earlier. Now, if we're living at Machu Picchu chronically with hypoxia all the time in our lungs, instead of going from some level here a little bit below 100 down to 75, we're going to go from whatever level we have in our alveoli all the way down to about 50. That's a significant increase in the unloading of oxygen, and that's going to be beneficial if we're living at high altitude. It's also helpful in patients with COPD and patients with chronic anemia, any situation where the body is chronically subjected to hypoxia. So if we go back to our causes of right curve shift, those were a high level of CO2, a low pH, and a high temp, and we can add to this list an increased level of 2,3-BPG. Anytime that happens, it's going to shift the curve to the right, and anytime the level of BPG goes down, it's going to shift the curve to the left. Now let's talk about fetal hemoglobin, which is hemoglobin F, and as I told you before, hemoglobin F is made up of 2 alpha and 2 gamma chains. After about 8 weeks of development, hemoglobin F forms in utero and is the predominant hemoglobin type. It makes up to 90% of the baby's hemoglobin. After the baby's born, the level starts to fall. There's still a lot of hemoglobin F at birth, but it starts to fall steadily, and then in adults it makes up less than 1% of total hemoglobin. The reason this is the preferred form of hemoglobin for babies growing in the womb is because it has a higher oxygen affinity than hemoglobin A. Remember that hemoglobin in the mother is going to be mostly bound to hemoglobin A, so you want a hemoglobin in the baby with a higher affinity so it will pull oxygen from hemoglobin A and bind it to hemoglobin in the baby. And this is very important because the fetal oxygen partial pressure is only about 40. In a normal adult, the oxygen partial pressure is about 90 or so. It's much lower in the baby when it's growing, so it needs a form of hemoglobin that very easily binds to oxygen. So what this means is that fetal hemoglobin is left shifted compared to regular adult hemoglobin. It has a higher oxygen affinity, and if we look at these two curves, the red could represent adult hemoglobin, the green would represent fetal hemoglobin. It's shifted to the left, it has a lower P50, and therefore it binds oxygen with higher affinity compared to adult hemoglobin. And the reason that fetal hemoglobin is left shifted compared to adult hemoglobin is because fetal hemoglobin has altered binding of 2,3-BPG. It's super high yield to know this for step 1. This is what they're going to want you to understand. In adult hemoglobin, 2,3-BPG binds to the beta globin chains very well. But in fetal hemoglobin, there are no beta globin chains. There are gamma chains, and 2,3-BPG does not bind gamma chains very well. For this reason, in fetal hemoglobin, there's less 2,3-BPG binding, and that causes the oxygen affinity to go up. In other words, that causes a left shift. Let me briefly mention myoglobin, which shares some similarities to hemoglobin. Myoglobin is a protein found in skeletal muscle and the heart. It's a single chain, not 4 chains like hemoglobin, and because it's a single chain, it can only bind one molecule of oxygen. You can create an oxygen saturation curve for myoglobin, and if you do, it will look like this green line here. And you can see that it's very different from the S shape of hemoglobin. And this green curve shows you why we are better off having hemoglobin in our red cells than myoglobin. At the partial pressures found in the lung, like 100, myoglobin is fully saturated. When you move down into the tissues at partial pressures like 40, myoglobin is still nearly fully saturated. So the problem we would have if we used myoglobin instead of hemoglobin is that our cells would never offload much oxygen, and that wouldn't be very effective for metabolism. But because we have hemoglobin, and because hemoglobin has this S-shaped curve, when we get down into the tissues, we unload lots of oxygen, and that's good for metabolism. I'll finish this video by talking about two special pathologic conditions that relate to hemoglobin and oxygen binding. The first one is carbon monoxide poisoning. Carbon monoxide is a gas, and it binds to iron in heme with 240 times the affinity of oxygen. When it does, it forms a structure called carboxyhemoglobin. Because it binds so avidly to hemoglobin, it blocks binding sites for oxygen, and therefore less oxygen can be absorbed by hemoglobin. This creates what's called a functional anemia. Basically, even though there is enough hemoglobin, the body behaves as if it's anemic because lots of the oxygen binding sites in hemoglobin are blocked. Not only can hemoglobin bind less oxygen, but it has trouble offloading oxygen. This is because carbon monoxide is an allosteric modifier of hemoglobin, and it shifts the curve to the left, and therefore less oxygen will be unloaded at any given partial pressure. So this slide shows the effect of carbon monoxide on the hemoglobin oxygen dissociation curve. A normal curve is in blue, and because of carbon monoxide, there's less carrying capacity of oxygen, so the whole curve moves downward like this. In addition, there's a leftward shift, so when you get down into lower partial pressures, more oxygen remains bound than if you were operating on the blue curve. People who are exposed to carbon monoxide poisoning usually have nonspecific symptoms. Headache is the most common, but they can also say that they have malaise or nausea or dizziness. A classic but very rare finding is to have cherry red lips. This occurs because carboxyhemoglobin is red, and so these patients will develop red lips, very different from the blue lips you see in patients who are cyanotic. Now, patients with carbon monoxide have a decreased oxygen content in their blood. However, the pulse oximeter is often normal. That's because it can't differentiate between carboxyhemoglobin and oxyhemoglobin. So it will say that 90% of hemoglobin molecules are saturated. It can't tell you that only half of those molecules contain oxygen, the other half contains carbon monoxide. The way you make the diagnosis is by measuring a carboxyhemoglobin level. A normal level is less than 3%. Smokers always have slightly elevated levels, like 10 to 15%. It's super high yield to know this for your boards. A level greater than 15% suggests carbon monoxide poisoning. And the treatment is oxygen. If you put lots of oxygen into the lungs and into the blood, it will push all those carbon monoxide molecules off, and they will be exhaled, and things will go back to normal. The second pathological condition I'll talk about is called methemoglobinemia. So most iron in hemoglobin is normally in the reduced state, which is Fe2+. But a very small amount is found in the Fe3+ state. This is called methemoglobin. And this hemoglobin is bad because it can't bind oxygen, but usually it's just a tiny bit of our hemoglobin, so it's not a big deal. If, however, a pathologic condition causes excess methemoglobin, this can lead to hypoxia because all the Fe3+ won't be able to bind oxygen. So what could cause an increase in the amount of Fe3+ iron that's found in hemoglobin in our red cells? Well, it turns out there are a number of drugs that can cause this. Local anesthetics like benzocaine are famous for doing this. Most patients who receive these drugs do not develop methemoglobinemia, but a small proportion do. Nitric oxide, which is an inhaled gas, sometimes administered for pulmonary hypertension, can cause methemoglobinemia. And then finally, dapsone, which is a rarely used antibiotic, is also known to cause this problem. The treatment is with a substance called methylene blue. It's a reducing agent, and it converts iron from the 3+ state back to the normal 2+ state, which can bind oxygen. So a typical clinical scenario for methemoglobinemia that you should be able to recognize for step 1 could be an endoscopy patient who receives benzocaine spray to the throat to cause numbness of the throat so that the probe can be passed into the esophagus. After the procedure, the patient complains of shortness of breath. When a blood gas is done, a classic finding is the presence of chocolate brown blood, and this occurs because methemoglobin turns blood brown. Measuring the oxygen saturation by pulse oximetry is unreliable. The results are variable depending on the severity of methemoglobinemia. You can get results that are in the 80s, which represent hypoxia, but you can sometimes also get normal results in the 90s. Importantly, if you give the patient oxygen, that's not going to make them feel better, and that's because the problem is not insufficient oxygen. The problem is that iron is in that Fe3+ state, which doesn't like to bind oxygen. When you measure the PaO2 by blood gas, it's going to be normal because there's no problem getting oxygen into the blood. The problem is getting hemoglobin to bind the oxygen. And you can make the diagnosis by finding an increased methemoglobin level, which can be measured in the laboratory. Besides a patient that receives numbing medicine to the throat, another classic scenario is a premature baby given nitric oxide for pulmonary vasodilation. And that concludes our video on hemoglobin.